SAPA for allowing PANDA this platform to present on this very important topic of status epilepticus in children. So my mandate for this talk was to talk about the state of the art in the management in resource unlimited settings in terms of management of status, and also to cover aspects of management in resource limited setting where many of us practice. So I'm going to try to cover both those areas in the next half an hour. So I've entitled my talk A Storm in the Brain because that's exactly what happens in terms of the chaos that happens at the neuronal level in children's brains when status epilepticus occurs. So in terms of an outline, I'm going to go through a case presentation, a little bit of epidemiology, definitions, because they are very important in terms of impacting management decisions, looking at the etiology, the management, the crux of this talk, and the treatment gap between resource limited and resource enriched countries or areas. So this case presentation is going to highlight things that can go wrong in terms of managing a child with status epilepticus when a protocol is not followed. And it's by no means meant to point fingers because hindsight is always 20/20 vision, but rather to reflect on how we can improve management of children. So this was a 6-year-old boy who presented to the GP initially with a history of a febrile illness. He was prior to this completely well, and this was his first episode of a generalized tonic-clonic seizure. There was no family history of note, and between the referral from the GP to the referral hospital, he was given multiple doses of lorazepam and diazepam. He also received a loading dose of sodium valproate, and he was started on ceftriaxone and acyclovir, which was appropriate in the context of a child with a fever and a seizure, covering for both bacterial and viral meningitides in the absence of a definitive diagnosis. He then had a lumbar puncture done, showed a normal chemistry, 22 lymphs, and no polys, which supported the possible diagnosis of a viral meningitis. He also had a CT scan done, and his CT brain was normal. This child continued sitting and was eventually transferred to the high care a few hours later, where he remained encephalopathic, and he received another dose of IV lorazepam at this stage, and not surprisingly, he had a respiratory arrest. He was then resuscitated and ventilated, loaded with phenytoin. He required a midazolam infusion, which he remained refractory to, and then had a thiopentone infusion, which eventually controlled his seizures. So at this point, his seizures were controlled, and he was started on sodium valproate and phenytoin maintenance. He required multiple maintenance treatments, and once he was controlled for 24 hours, he then was successfully weaned off the thiopentone. So in summary, this child had a presumable viral encephalitis and status epilepticus that was inappropriately managed, unfortunately, and as a consequence developed severe sequelae of global neural regression, cortical visual impairment, hearing impairment, dyskinesia, and he had a pseudobulbar palsy that needed a gastrostomy. This slide shows his MRI scan, which shows bilateral hyperintensities in the basal ganglia, which are compatible with his history of having had a hypoxic brain injury that was acute in nature. And the picture next to the MRI shows his EEG, a picture which shows a burst suppression pattern, which is in keeping with what you would expect in a patient with who is on a dose of thiopentone. So this child unfortunately had a poor outcome, and the main reasons for this and the things that went wrong was that there was no protocol that was followed. And as you will see, a theme throughout this presentation, the most important thing in the management of status epilepticus is to have a protocol. This child also highlights the danger of repeated doses of benzodiazepines and delayed referral to ICU, which in our circumstance may be unavoidable looking at the very limited number of ICU beds that are available to many of us. So by way of an introduction, status epilepticus is an acute, potentially life-threatening neurological emergency that requires prompt therapy. And the reason therapy needs to be given promptly is from the pathophysiology of status epilepticus. We now know that there is a progressive time-dependent development of pharmacoresistance if patients are not treated promptly. The modern era and what is the most significant development in contemporary epileptology is that there has to be a protocol-driven approach. And this protocol-driven approach alone has improved outcomes. As you will see from the evidence that I present, there are no large randomized controlled trials, despite status epilepticus being a common problem that afflicts so many children and causes such devastation in so many families. And a lot of our practice is based on experience and anecdotal evidence. But the one thing that is quite clear, despite there not being enough evidence, is that time is growing. The longer or the more time that is wasted in treating status epilepticus, in implementing a protocol, the more severe brain injury and poorer outcomes we see. So epidemiology often bores a lot of us, but I think it is significant and relevant for us to understand the extent of the problem as well as outcomes so that we can change management and improve outcomes. So the incidence overall globally is thought to be between 17 to 23 episodes per 100,000 children. And the incidence also differs significantly between in different regions of the world, as you will see in subsequent slides. And about 25% of children will develop refractory status epilepticus, which has a worse outcome. And if we take all children with epilepsy, about a quarter of all these children will have at least one episode of status epilepticus in their lifetime. And about a third of all newly diagnosed epileptics will present in status epilepticus as their first presentation to a healthcare facility. If we look at more local data, a Kenyan study put the incidence at between 28 to 46 per 100,000 children per year. And a very small study in a very circumscribed area in South Africa, Edencourt, put the incidence as about 2 per 1,000 people. We also know that there's a bimodal incidence in status epilepticus. It occurs more frequently in children under the age of 1 year, which is relevant to our practice, and in the elderly over 65 years. Convulsive status epilepticus is also a more common form than the non-convulsive form. This is a review of the burden of pediatric status epilepticus, looking at different regions in the world. And this came out of a recent paper from the journal Seizure. And to summarize this paper, it puts the incidence at about 1 per 50 children per year. And there's, again, the peak was between 1 to 2 years of age, and it was mostly convulsive status epilepticus. And happily, the mortality is lower in children than it is in adults with status epilepticus. So status epilepticus is a heterogeneous clinical syndrome. It's an electroclinical syndrome with a clinical manifestation and an electrical correlation with many causes and a very inconsistent clinical presentation. And the outcome, as you will see, is also very variable. So going into the definition, the first formal definition of status epilepticus was put forward in 1962 at this colloquium in Marseille, where the modern conceptual basis of status epilepticus was put forward. Intuitively, one would think that status would be any seizure that causes neuronal damage. However, this is an impractical definition because neuronal biomarkers for injury are not easily accessible or easy to interpret. So the next definition that was put forward was in 1981 by the International League Against Epilepsy. And for neurologists throughout the world, the International League is considered the holy grail for anything epilepsy related. And this definition stated that status was any seizure that persisted for a sufficient length of time, was repeated frequently enough, and there was no recovery between the attacks. And you can see the immediate fault or problem with this definition is that there is no time duration. So this point in time when a prolonged seizure becomes status epilepticus has changed dramatically over the last 20 years. Most of us would remember from medical school days, the definition we were taught was status epilepticus is any seizure that lasted more than 30 minutes or a series of seizures where there was no return to baseline level of alertness between the events. And the problem with this definition and why it needed to be rethought was it was based on animal studies that neuronal injury starts at about 30 minutes if a child has a prolonged seizure. And this point in time of 30 minutes, if we use it to direct management, would be too little too late because neuronal injury would already have started happening. So the reason this definition was rethought about was any definition that we use should direct how we manage patients. And clearly 30 minutes is too late to start implementing management. In resource-poor settings, duration is rarely documented. Most patients arrive convulsing at a clinic or a hospital, and the caregivers cannot remember or document the duration of the seizure. But what is being made abundantly clear is that there is increasing recognition from pathological data that medication administration delay results in refractoriness of seizures. So essentially, the longer we take to treat the child, the less likely we are to succeed in controlling the seizures. And on a pathological level, we know that this is because the GABA receptors on neurons, which is the main site of action of most of our anti-epileptics, become internalized as the seizure progresses. And therefore, if the child is fitting for a long time, if you use drugs that work on the GABA receptors, there would be no substrate for these drugs to work on. And taking into consideration all these factors, an operational definition was put forward by the League in 2015. So this is an operational definition, but there are two conceptual dimensions or operational dimensions to it. This definition talks about two time points, time point T1, which indicates when treatment should be initiated, which is the most important part of the definition in terms of practice, and time point T2, when long-term consequences or when brain injury starts becoming apparent. So putting all of this together, the definition that is now widely accepted as the definition of status epilepticus is a condition resulting either from the failure of mechanisms responsible for seizure termination or initiation of mechanisms which lead to prolonged seizures, after which long-term consequences can occur. I'm just going to tell you very briefly about the definitions of refractory and super-refractory status epilepticus, although these conditions are managed primarily in ICU settings. So refractory status is a seizure that persists for more than 60 minutes, despite the use of an initial benzo and an appropriate second-line anti-seizure medication. And super-refractory status is status that has continued or recurred despite at least 24 hours of general anesthesia. But these two forms or subtypes of status epilepticus are generally managed in an ICU setting and are a talk on its own. So looking at those two time points of T1, when we should be starting treatment, and T2, when brain injury starts occurring, this is most well studied and defined in generalized tonic-clonic status epilepticus. And time point T1 is considered to be 5 minutes with generalized tonic-clonic status. And time point T2, when long-term injury is going to happen, is 30 minutes. The less common forms of status epilepticus, which is the focal non-convulsive status epilepticus, and absent status epilepticus, we know less about the time points in these two definitions, but these are being worked on, and I'm sure definitions will be more definitive in the next few years. So another very important part or aspect that this paper touched on was an axis classification of status epilepticus. And this was broken down into 4 axes. Axis 1 talks about the semiology or the type of status epilepticus. And axis 2, which is beyond the scope of this talk, is the EEG characteristics of status. Axis 3, which I will touch on a bit, is the etiology. And the last aspect would be the age groups at which status epilepticus occurs. And it's divided into neonatal, infantile, childhood, and adolescent status epilepticus for our purposes. So looking at just axis 1, where the semiology is expanded on, this was broken down further into whether there were prominent motor symptoms, which and the commonest of this type would be the convulsive status epilepticus or the tonic-clonic status epilepticus. And then the less common form with the motor symptoms would be myoclonic, focal motor, tonic, and hyperkinetic. The non-convulsive status epilepticus or the status epilepticus without prominent motor symptoms is a difficult one, because these children are hard to recognize without an EEG. And the commonest area we encounter these patients are children who've had convulsive status epilepticus and are now in an ICU setting, sedated and sometimes even paralyzed, and you are unable to appreciate the motor symptoms for this reason. And it is estimated that about 20% of children who have convulsive status epilepticus go into non-convulsive status epilepticus. And this is quite scary because many centers do not have continuous EEG monitoring, and these children may go on fitting with no apparent motor symptoms. This looks like a very busy slide, but I like it because it emphasizes that status epilepticus does not just affect the brain, and it also highlights the importance of why it is so vital for us to act timeously because of all of the changes that occur systemically and in the brain as time goes on. So there are metabolic changes, there are changes that happen in the cardiovascular system, and most importantly, the injury that occurs to the brain. So looking at the etiology, this differs significantly between first and third world countries. And it is important to establish the etiology because this will directly impact both management and also the underlying etiology of status epilepticus is considered to be the most important determining outcome in working out the outcome of the child. In third world countries, unfortunately, infectious etiologies remain the commonest cause of status epilepticus. Trying to make this point out. And anoxic status epilepticus is associated with the worst outcome. So this paper that I referred to earlier from 2019 from the journal Seizure tabulates very nicely the different arms of causes of status epilepticus. So the symptomatic or the known or symptomatic cause is further broken down into acute symptomatic, and the commonest cause of acute symptomatic in most practices is febrile seizures. And the FebStat study from a few years ago showed that up to 50% of children with febrile seizures have an underlying HHV6 infection. Other causes or acute symptomatic causes would include things like a stroke, traumatic brain injury, electrolyte abnormalities, as well as CNS infections. The second arm of the symptomatic causes would be the remote symptomatic causes. And this group essentially refers to children who have a remote symptomatic cause. So a child who's had birth asphyxia, for example, and has underlying neurological disability, has epilepsy, but is well controlled, but now comes in with a breakthrough seizure. And the most common reason for these breakthrough seizures would be subtherapeutic drug levels, or an intercurrent infection that triggers the presentation. And the third group would be the progressive causes. So this would include things like child with a brain tumor or neurodegenerative disorders. The electroclinical syndromes and are syndromes like Lennox-Gastaut syndrome or Dravet syndrome, and many of these children with these severe underlying epilepsy syndromes are prone to status epilepticus. And the third group is the group we don't work out the cause for. So this table looks at the etiologies from a global audit of looking at Asia, Europe, and North America. And interestingly, infection rates may be higher in the East and in African countries, but infection remains the driving cause of status epilepticus throughout the world. Other causes to comment on this table are the immunological causes, so the autoimmune epilepsies or the autoimmune encephalitides, which are being increasingly recognized. And as the field of genetics expands, we are recognizing more genetic epilepsy syndromes that are predisposed to status epilepticus. This is an audit or a paper from our unit that was published a few years ago, and it looks at the etiologies of status epilepticus in children in the ICU in Nkosi Albert Lutuli Hospital in Durban. So again, you would see that the acute symptomatic causes are the commonest cause in our setting, and of these, infections again remain the commonest cause. And the infections were attributed to viral encephalitides, bacterial meningitis, as well as TB meningitis. Interestingly, the second commonest cause of status epilepticus in this ICU study was gastroenteritis with metabolic derangements. And here, the commonest cause was the hypernatremic gastroenteritis. I'm just going to mention very briefly these two concepts that have recently emerged, and you may come across it in your reading. And these two concepts are that of the new onset refractory status epilepticus and FIRES, which is the febrile infection-related epilepsy syndrome. So NOS, or the new onset refractory status epilepticus, is considered to be a clinical presentation and not a specific diagnosis. So this refers to a patient with no pre-existing risk factors. So there's no history of epilepsy or a neurological disorder, and so this previously well patient presents with new onset status, and after initial investigations, no clear etiology is identified. And FIRES, or the febrile infection-related epilepsy syndrome, which is the commoner or is a subcategory of NOS, is the one that affects children more commonly. And it refers to a group of children who present with status. The definition requires that this patient having had a previous febrile infection, and this fever may have actually occurred between 2 weeks to 24 hours prior. The patient does not have to have fever at presentation, but there would have been a history of fever sometime in the 2 weeks prior to presentation. The etiology for this group of conditions remains unclear. There are many theories that there may be a genetic predisposition with a superimposed autoimmune mechanism. And the important thing about this group of conditions is they are refractory to most anti-seizure medication. We've had a few children in our ICU with this condition, and they respond to nothing. And based on what understanding we have of the underlying etiology or pathophysiology, they sometimes may respond to immunomodulation like metacrid or IV immunoglobulins or the ketogenic diet. But this is really this group of patients are a nightmare to manage, as they are refractory to all modes of conventional treatment. So, what do we do when we are faced with a child who has status epilepticus? The most important thing is to recognize the patient. There are conditions that may mimic status epilepticus, and this would include movement disorders as well as conversion disorders. And it is important to keep these at the back of your mind. Um, Also, to remain cognizant of the fact that in some children with prolonged seizure activities, their movements or the tonic-clonic movements may become more gradual and subtle, and you do not want to miss this. And as I said earlier, this is especially so in an ICU setting in a paralyzed patient. And these patients may, and when you should suspect this is when a child remains obtunded for a prolonged period, even after the midazolam infusion, etc., is being turned down. And for all of these reasons, there is now compelling evidence for the role of EEG monitoring in an ICU setting. So as part of the initial management and assessment would be the first aid measures and checking the glucose, because this is hypoglycemia is an imminently treatable cause of status epilepticus. And while doing this, one should try to get a brief history and a rapid neurological examination. Things on the history would be whether this child is a known epileptic or is this his first presentation, and give high flow oxygen, because we remember from that diagram of what goes on in the brain when a child is fitting, the oxygen demands increase, and therefore we have to supplement the oxygen. If you can, call for help, establish IV access as soon as possible. And I think one of the very important developments in contemporary epileptology is empowering families and communities to start treatment outside of the hospital, either with midazolam or rectal diazepam, because, like I alluded to earlier, time is brain, and the sooner you initiate treatment, the more likely you are in being successful. So in an ideal world, the anti-seizure drug or medication that we would like to have, we'd love to have, would be something that can be given intravenously, has very few side effects, penetrates the blood-brain barrier, has easy pharmacokinetics, works well, and our setting is not very expensive. But I don't think we'd reached this level of developing a drug of this sort as yet. So this is a guideline that was published by the American Epilepsy Society a few years ago, and a lot of our EDL recommendations come from this guideline, and it is quite a useful article to read. When we talk about the management of status epilepticus, most guidelines divide the management into phases that are time-based. And as I said earlier, there are very few randomized control trials that direct how we should manage patients. And the phase 1, or the 0 to 10-minute phase, is the only phase with good scientific basis for the recommendations. There is good level A evidence based on 3 class 1 trials that benzodiazepines should be the initial agent of choice. And the options we have, if there is no IV access, what is tabulated on the slide at those doses: rectal diazepam, intranasal midazolam, or IM midazolam. The issue with intranasal midazolam is you need a specific device to deliver the drug appropriately, and this is not available in most settings. The Rampart trial, which was published about 3 years ago, compared IM midazolam to IV lorazepam. And interestingly, they were equally effective in terms of controlling seizures. And patients who got IM midazolam were found to be less likely to require ICU admission if they got IM midazolam as their initial drug of choice versus IV lorazepam. And the point of this trial was to look at what would be the most appropriate drug, or what would be the most effective drug to give children in the pre-hospital setting by paramedics, and if no IV access was available. And probably the recommendation would be in a controlled ICU or a ER setting, IV lorazepam would be preferable. But in the out-of-hospital setting, iomidazolam works just as effectively. Or if you can't get IV access, iomidazolam is a reasonable choice. If IV access is available, drugs that are recommended would be IV lorazepam or IV diazepam, and there is level A evidence to support this. Our EDL recommends IV lorazepam as the drug of choice, and any of these benzodiazepines can be repeated at least once. So looking at what the Cochrane database says about this phase 1 managing status epilepticus, and the summary of what the Cochrane database says is that IV lorazepam and diazepam have similar rates of seizure cessation as well as respiratory depression. There are low, if drugs are given at the right dose and not repeated too many times, the risk of adverse events, especially respiratory depression, is quite low. And when comparing efficacy of IV agents versus IM agents, the time factor that is needed to establish IV access must be taken into consideration. And again, they recommend buccal midazolam, rectal diazepam, if the seizure is going on for more than 5 minutes. And this review says that there's no evidence to support intranasal midazolam or lorazepam. So moving on to phase 2 of the management of status epilepticus, which is between 10 to 30 minutes after the child has started fitting. This phase has gone from no evidence to emerging evidence over the last few years. And the ESET trial looked at different agents in this phase, and it compared IV phenytoin or fosphenytoin to valproate, levetiracetam or Keppra, as you may know it, and phenobarb. And the conclusion of the study was that there was no significant difference in terms of efficacy when we look at each of these agents. Phenytoin was associated with more adverse events in terms of cardiac side effects and arrhythmias. With IV valproate, the caution is if there is an underlying metabolic disorder, especially mitochondrial disorders, liver dysfunction, then IV valproate can be detrimental. Levetiracetam, the IV formulation is not readily available. In the private sector, I know it is available once you fill out a Section 21 form. And IV phenobarb, we all know, is an old drug. We all used to, we all comfortable with using it, but the problem obviously is the availability in many settings. So the summary of what drugs we should use in phase 2, the ESET trial established that there's not much difference in terms of efficacy. So I think our choice of agent would depend on cost, what is available to us, and that is very often dependent on where we practice. And then obviously if the child has specific underlying problems like liver dysfunction or metabolic dysfunction, then that would preclude you using a drug like valproate. What about oral phenobarb? Is there a role in management of status epilepticus? And this whole debate or point was brought forward by a paper that was published from Red Cross Hospital a few years ago. This was a trial of about 16 patients that looked at the efficacy or the role of phenobarb, oral loading doses of phenobarb. And the reason this was done is at that point in time, there were no IV formulations available of phenobarb, and there were very limited options in how to treat these children. And this trial found that adequate serum levels were achieved after oral loading doses. But I think the caution with using any drug in an oral formulation in a child that is fitting would be time to action, because you need something that's going to work quite quickly. And also what would be of concern is what would be the perfusion of the gut and what would be the absorption of this drug in a child that is potentially hemodynamically unstable. So I think the role would be is once the child has been stabilized and you're trying to, and you don't have too many options available, and you're trying to establish good serum levels of an anti-seizure medication, or phenobarbital would then be an option. There were two trials done more recently comparing levetiracetam versus phenytoin for second-line treatment in pediatric convulsive status epilepticus. And these were multi-center, open-label randomized trials. And again, the conclusion of this was that levetiracetam is not significantly superior to phenytoin as a second-line agent. So phenytoin is just as good. The only aspect in which levetiracetam came out better was in terms of the safety profile. Then moving on to phase 3, or when we've gone to more than 30 minutes of having seizures, at this point, in terms of evidence, we are on very thin ice. There are no randomized controlled trials that can direct us. And ideally, at this time, the child should be in an intensive care or high care setting, and in an ideal world with EEG monitoring. The child is under 18 months, consider rhodopsin-dependent epilepsies, and often this is tried if the child is not responding to conventional anti-seizure medication. In terms of what options we have available to us, IV midazolam infusion is what we all probably most au fait with. And then other drugs that are used, thiopentone infusion. I know that there's been an issue with stock and availability of even thiopentone in many sectors. And then propofol infusions and ketamine infusions are other options should the child not just respond to midazolam and thiopentone is unavailable. Is to be wary of the propofol infusion syndrome, especially in young children, where there may be hemodynamic problems as well as renal toxicity. So, putting all of that information together is how our EDL recommendations were put forward. And our EDL recommends IV lorazepam if you have IV access. And if there's no IV access, the options would include IM lorazepam, rectal diazepam, buccal midazolam in the early status epilepticus phase, which is under 5 minutes. Once you're going to establish status epilepticus between 5 and 30 minutes, benzodiazepine can be repeated, and the other options would be phenytoin, loading dose of phenobarb IV if available. If the child continues fitting, you can use the alternate options. So if you've used phenytoin, you can now use phenobarb or vice versa. And at this stage, the child should be referred to an ICU. In the ICU setting, once you've gone into the phase of refractory status epilepticus, midazolam infusion or thiopentone if the child remains refractory to midazolam. And while we are doing all of this, to remember that all of the drugs, as well as the status itself, has implications for systemic complications and adverse events. And one should be wary of these possibilities of hypotension with thiopentone or midazolam and offer appropriate cardiorespiratory support. Other complications that may occur while you are managing the seizures include respiratory depression, aspiration, raised intracranial pressure, if there's ongoing seizures, cerebral edema may potentially occur, and the treatment options for this would include IV mannitol or a sodium chloride and or steroids if there's an associated space occupying lesion. And this is what is also recommended by our EDL. Also remember that there may be other systemic complications like central DI or syndrome of inappropriate ADH secretion, and these need to be managed because concomitant electrolyte abnormalities may exacerbate the seizures. And also remember musculoskeletal complications like rhabdomyolysis and joint dislocation. So what can be said of the treatment gap? we know that the burden of convulsive status epilepticus in resource-limited settings is probably far more than in resource-rich settings, but because of very few epidemiological studies, the exact extent of the problem is not known. And some of the factors that make things worse in resource-limited settings is the lack of many second-line anti-seizure medication. Supply of drugs is erratic. At some point or the other, we don't have one drug or the other. There's significant delay in transporting patients to hospitals. We have very few ICU beds available, and obviously empowering caregivers, including trained doctors and nurses to manage these children. And then looking at other more experimental modalities of treatment, isoflurane, which is a GABAergic agent. And then now that we are becoming cognizant of the fact that many of these unknown causes of status epilepticus probably have an autoimmune mediated mechanism, steroids, IV immunoglobulins, and plasmapheresis are being used. And then the ketogenic diet has also been used in the acute setting of status epilepticus. And then in terms of more experimental therapies, neuromodulation options like vagal nerve stimulation and ECT is also used. So how do we investigate these children once they come in and once you've stabilized them? There is no one-size-fits-all or tick box for what one should be doing. The clinical scenario, the history, the clinical examination put together would determine what diagnostic investigation should be done. And it is also very important to remember that monitoring and ensuring patient safety must remain paramount while you're searching for an etiology. And you should only start extensive investigations once the patient has been stabilized. And the investigations of a child who's presenting for the first time is distinctly different from those children with epilepsy, who are known to have epilepsy, who are now coming in breakthrough seizures and status. So this is a box or a flow diagram or a recommended diagnostic workup for children with refractory status, and the common sense investigations that are always indicated would be the bedside glucose test, monitoring vital signs, and then looking at neuroimaging, electrolytes, and if you have access to it, continuous EEG monitoring. And then what of children with known epilepsy who present now in status epilepticus? So here, presumably that if the child has had epilepsy, there have been some investigations done for working out the cause, and therefore imaging will become less urgent because presumably it has been done. What would be more important in these children would be looking for what potential trigger there may have been, and often it is in systemic febrile illness, doing drug levels if the child has if the family is non-compliant, or they are already interacting with their anti-seizure medication and dropping the levels. Number punctures and cultures, which should be very individualized in children who are known epileptics. Then what do we do? If the child has now stopped fitting and is stable in the ICU on his midazolam infusion, what would be the next step? Prior to weaning off any infusion, it is vital to make sure that you have started some maintenance anti-seizure medication. Ideally, we should confirm that there's no non-convulsive status epilepticus on the EEG before we start weaning down an infusion. We should also try to optimize maintenance treatment. So if you've put the child on phenobarb while he's been on the midazolam infusion, make sure that the serum levels are therapeutic before we start weaning down an infusion. And tabulated on the slide is the recommended rates for weaning down infusions. Again, this is not evidence-based, it's based on practice and experience. And generally, if a child has been refractory and needed a long time to get control of the seizures, the principle would be to wean the child more slowly, rather than somebody you were able to control quite easily. And if the child has a breakthrough seizure once you start weaning down the midazolam with thiopentone, you should rebolus the infusion of the drug that you are using and take the infusion back to the rate that you had before the seizure occurred. And while doing this, you should optimize or add on other maintenance anti-seizure medication to ensure that once the infusion has been turned off completely, there are enough maintenance anti-seizure medications on board to prevent further breakthrough seizures. And finally, looking at outcomes, because this is the greatest judge of whether how well or how appropriately we've treated the patient. So the determinants of outcome, the most important factor here is the etiology, and patients with acute symptomatic causes have a worse outcome. And as I said earlier, anoxic or hypoxic status epilepticus has the worst outcome. Time to treatment, like I've said before, the longer you take to start your anti-seizure medication, the less likely you are to get control and worse the outcome. Children under the age of 5 also tend to have a worse outcome, and if the seizure has gone on for a longer period, logically, those children would also have a worse outcome. Unfortunately, children overall tend to have a lower mortality than adults, and some of the long-term morbidity associated with status epilepticus includes neurological deficits, long-term epilepsy, cognitive impairment, behavior problems, and a risk of having a second episode of status epilepticus. So in conclusion, I hope that I've convinced you that status epilepticus is a life-threatening emergency, and protocol-driven, time-sensitive approaches is the most critical aspect of the management. So as you have seen from the evidence, there isn't a lot of evidence for any specific protocol. And I think the appropriate management should not be around the nuances of what the 5th or 6th line drug should be, but rather that we have time schedules for when we should abandon something, a protocol that is not working, or when we should move on to the next agent. And you should stick very strictly to these time schedules. And this alone, following a protocol, has improved outcomes in status epilepticus. Our current clinical practice is further challenged by the heterogeneous nature of the etiologies and multiple factors involved in a child that goes from status to refractory status to super refractory status. We are further challenged by the limited number of drugs we may have access to, or lack of availability of many of the drugs. And there are no large randomized controlled trials, like I've said before, supporting a specific algorithm. It is just vital that we have a protocol-driven approach, and this impacts the morbidity and mortality. Remember again, time is brain, and this should compel you to act timeously. And while we are treating the child, to remember that side effects of therapy and systemic complications occur, and you need to be cognizant of these and manage these appropriately as well. Okay, so these are my references, and thank you for your attention.